Hello, everyone. I am Oita Coleman, project lead of the Open Voice Trustmark Initiative, an independent project of the LF AI and Data Foundation, and moderator of today's webinar. Before we begin, let's handle a few housekeeping items. Next slide. This webinar is governed by the Linux Foundation antitrust policy and is being recorded. It started on time and it will end on time. As we go through the webinar, feel free to post your questions in Q&A and we'll address them at the end. Next slide. Worthy of trust. The founding vision of the Open Voice Network and the North Star of the Open Voice Trustmark Initiative. Our charter is to establish a framework of trustworthy AI principles, education courses, best practices, white papers, and tools to deliver on that vision. Based on the solid foundation of the trustworthy AI principles of privacy, transparency, accountability, inclusivity, sustainability, and compliance. Next slide. One of our focus areas is health and wellness. We are announcing the publication of our white paper, Conversational AI Technology and Remote Patient Monitoring, a call to action. In no other area of our lives is the need for trust and duty of care than in healthcare. Industry experts know there is a growing crisis in health and wellness delivery driven by demographic, professional, and socioeconomic market transitions. Conversational AI, remote patient monitoring, is an important response to this crisis. The white paper is a collaborative effort in partnership with organizations such as Intelligent Health Association, Bridge to AI, Nationwide Children's Hospital, Canary Speech, University of Central Florida, TQ Intelligence, and others within the Open Voice Health, Wellness, and Life Sciences community. We are fortunate to have two industry experts and contributors to the white paper. Join us in today's webinar. Dr. Kumah-Crystal is a pediatric endocrinologist and biomedical informaticist at Vanderbilt University Medical Center. Her research focuses on enhancing communication within the electronic health record system through documentation, voice technology, and the exploration of generative AI pathways. She works with the telehealth task force to develop strategies that leverage remote patient care models. She continues to be clinically active, supervising pediatric endocrine fellows and treating her own clinic patients who know her as Dr. Ya. And she is also a member of the Open Voice Trustmark Initiative Advisory Board. Welcome, Dr. Ya.
It's an honor to be here.
Bill Paschall is a subject matter expert in the areas of remote patient care, policy, and reimbursement, and a sought-after speaker on telehealth and healthcare technology issues. A past board member of the American Telemedicine Association and a graduate of Oral Roberts University, Bill Paschall is knowledgeable in healthcare product innovation, research, design, training, marketing, and sales strategy. He joined Mobile Health, ClearArc Health in 2022 as Senior Vice President of Growth and Strategic Accounts for ClearArc Health. Welcome, Bill. Glad to have you.
Thank you, Oita. It's a pleasure to be here today.
All right. Bill and Dr. Ya, I briefly mentioned the healthcare crises. Let's begin by exploring this further. So specifically, I want to start by highlighting these data points. The World Health Organization estimates there will be a shortage of 15 million health professionals by the year 2030. They also report that between 2015 and 2050, the proportion of the world's population over the age of 60 will nearly double from 12% to 22%. Here in the US, 86% of healthcare costs are going towards an epidemic of chronic health conditions. And furthermore, there is a disparity in health equity, especially for underserved populations. I'd like for each of you to take a few minutes to briefly describe these challenges and why your work is important and how it addresses these challenges. Bill, let's start with you.
Thanks, Oita. You shared some really good information just there. And some additional things to consider is while the number of healthcare professionals is declining on both the physician provider side and on all the ancillary care RNs and others who would be clinical staff to help manage these patients for remote monitoring and other conditions. In the US and across the globe, that population is aging. So we've got the population trend going up, care provider trend going down. That's a big X in the middle. And the only way to bridge that gap is the utilization of technology with appropriate human intervention and escalation. So we see, by some reports, as many as 10,000 people a day here in the US are turning 65 and over. So that's, you take 86% of those with chronic conditions, that problem is getting more and more every day. Then we've got some additional factors. The global remote patient monitoring market size and the US market size, depending on what reports you look at, and they vary widely, but typically we see things like by 2030, the remote patient monitoring market in the US will be about $1 billion, and globally by that time will be, estimates are 10 billion to 100 billion, but let's say 10 billion for that. So that's growing. You mentioned the rise in chronic conditions. So all of those factors come together, really exacerbate this need for remote patient monitoring. And the traditional remote patient monitoring programs have done really well, the solutions, but conversational AI, it can be a tremendous help for that. We'll talk a little bit more about how we use that in a moment.
All right, thank you. Bill, Dr. Ya.
I echo everything that Bill has raised, and the statistics you gave are quite astounding. I think one of the most interesting aspects of the evolution of care is, if everyone can remember, way back when, 4 years ago, 2020, with the pandemic, how it really forced us to contend with how we were delivering care in the first place and what the existing care models were. When we had to rethink whether requiring everyone to come to our brick and mortar hospitals in order to get access to high level appropriate medical care was the right thing for patients. When we were required to stay home for our own safety, we had the ability to really rethink whether it made sense to continue care the way it currently did. We had an explosion in telehealth, which was remarkable. Providers found it very beneficial as ways to stay in contact with their patients between clinic visits. Patients found it very beneficial because it took a lot of the logistics and planning out of having to go see your doctor. And then we had other models that started to scale up as well. So I think one of the silver linings of having gone through the pandemic is that it really shook up things in a way that when things are the status quo, you don't really have motivation to change. But now that we have had a peak of how things could be and are having to reckon with the numbers that you described before, I think we're going to have to take a real close look at how care needs to evolve to meet the patients where they are, figuratively and literally, because what we're doing right now is not really sustainable.
Yeah, very good points that the two of you have made, and just tying those two things together. So we are now at this inflection point at X, as Bill mentioned, where they decrease in the number of providers, and then there's the increase in aging population and chronic health conditions that really just exacerbate the need. But then we had the point, as you mentioned, and during COVID, where we are now motivated to where we may have been complacent, right? To we now have the motivation, and probably, as you both know, Bill, with your work, the economic incentive to do something, right? There's the need, as well as a need to manage healthcare costs from a patient care, from provider care. I'm sure those challenges are things that both of you, in your work, you are attempting to address. So, Bill, you are a pioneer in the area of remote patient monitoring, specifically conversational AI and voice AI. And your role at ClearRock Health, you've been instrumental in defining what is considered today's RPM toolkit. So, in terms of tools for developers as well as healthcare providers, can you share more about the work that you're doing at ClearRock Health?
So at Clear Arch Health, we have really kind of two components of the business. Under mobile health is personal emergency response solutions and automated fall detection. And that's been around for a longer period of time. Clear Arch Health is the B2B side of it on the healthcare industry for remote monitoring solutions, where we have integrated both remote monitoring and personal emergency response. So we've got a decade and a half experience on direct to healthcare consumer experience, primarily with voice phone calls, which have been human led for most of that time. Recently, we have adopted some AI tools, primarily in the areas of eligibility, enrollment, and onboarding, training. So those are pretty simple areas to utilize AI tools as voice and bring those in. So that's fairly simple. I see a real need for it, and things that we're looking at right now are on the logistics side of things. We send out these, and sometimes a pretty fancy kit of a tablet that's capable of video conferencing, connected with multiple personal health devices, goes direct to a patient's home in a kit with easy on instructions via video and things like that we already do. Tech support call that comes next, currently human driven, it could be AI driven. But on the back side of that, when the patient is able to control their chronic disease, for example, many programs run 6 months, some that are really geared on reducing hospital readmissions, for example, may run 30 days. So the programs sometimes run for a finite period of time. Then we need to bring that back in, have that clean, disinfected, to FDA standards. So how do we get that back? Right now, that is a huge human effort. So on that retrieval side, having assistive communication technologies, assistive voice technologies assist on that will be a real value add, economic driven, money saving component to the solution, which means we can offer that for less cost to our customers. Those are probably the biggest areas that I see in kind of the business side for remote patient monitoring. Then it's as we are monitoring the patients, one of the things that's required now is there's 20 minutes of care that's for the time-based codes like remote physiologic monitoring, 99457, 99458, 20 minutes each of human time spent looking over those medical records, looking over the alerts, making care plan changes, and doing an interactive communication with the patient. Interactive communication right now means real-time audio video between two humans. At some point in the future, it'll be great to see some policy changes on the Medicare side of things where conversational AI could be assistive to that, and be a component of that. So those are things that that we see coming down the road.
So I would like to, when we do a follow-up question and another segment, to hear you elaborate more on the policy, the need for additional changes. So I'd love to make sure we circle back around and cover that as we talk about what's the next step, what needs to happen next. So Dr. Ya, as a clinician, can you talk about using these technologies in real world setting, the work that you're doing at Vanderbilt, at the medical center there, and give some examples and use cases as well?
Absolutely. So Vanderbilt had a hospital home program that was an extension of our COVID at home program that arose during the epidemic and the pandemic. And we are seeing patients that meet certain criteria for the level of care they need. And after they meet the criteria, they're eligible to receive care that's monitored at home. As Bill was alluding to, we have monitors that track their heart rate, their blood pressure, their weight, the respiratory rate, things like that, their glucose, so that we can get real-time information to track on this dashboard how patients are doing over time, and also to alert us when patients deviate from what the expected parameters are that's customized for their needs. In addition to that, there's a telehealth component to it as well. So they have the ability to reach out at any time to our command center, where they can ask additional questions if they have questions about their medications or how they're doing. And then their interactions with our nurse practitioners, our physicians on a continual basis to check in on them. Because one of the concerns that was raised was, if we have patients that are being cared for at home versus in the hospital, are they getting the same level of care? Are they getting the same level of attention? And we actually found, we have data to support this in the COVID at home program, patients were discharged and improved faster when they were at home than when they were in the hospital, for several things. And feedback we've gotten include just having awareness of their family members about some of their activities of daily living that they'd have to pay attention to, being more accustomed to their environment at home. All of these things help people feel taken care of. And part of the care we deliver is not just the medications that we give and the tracking that we do, but also letting them know that we understand that they have needs outside of the hospital walls that can help them heal as well.
Great information there. One question that comes to my mind as you talk about the recuperating at home, and that patients there improve quicker in a home setting. And I'm wondering, do you also have data regarding the caretakers and the caregivers who would be in a better position to help care for the patient as well? Do you have data? What is your experience there with the whole?
That's a great question, actually, because another concern, because we're talking right now about care being delivered at home, but we have lots of care models that exist right now where there's home health, where patients with chronic disease, I'm a pediatric, so we have a lot of patients with developmental needs that have, home nurses that come to help facilitate the care of these patients. With hospital at home, there was a concern that we were potentially adding burden to caretakers, because it's a lot of work to take care of someone who's ill, and what support would we be able to provide them to facilitate the care. But with the patients that we would take care of with chronic conditions such as like UTIs or cellulitis, things along those lines, we found that having the in-home experience allowed those people to learn more of the chronic management these patients would need. Because when you're in the hospital, the nurses are coming in and out, it's impossible to get sleep. When they were doing it at home, they actually, again, were in their own environment. They'd have the nurse there to teach them the things that they'd be doing and things they continue to do even after they were discharged from the hospital. So the learning environment was more beneficial, in fact, for these caretakers.
So it's great to hear from both of you that the adoption, especially on among the patients, because I guess we were all COVID kind of forced us to get used to, telehealth, telemedicine, because we could not go into it. So now again, looking and reflecting on that, on the advances, the reality is that with great advances come great responsibilities, right? The use of conversational AI to deliver remote patient monitoring demands careful consideration of legal and ethical issues. They was not stress that these should not be seen as barriers to innovation and work that you're doing. But developers, clinicians, and providers, encouraged to factor in these issues as they begin to design and implement solutions. So, Dr. Yar, what do you see as the challenges there, especially in light of voice and now the use of large language models regarding legal and ethical issues?
I think this is a really exciting time that we'll be able to explore how these technologies can be intelligently integrated in our care delivery paths. As Bill mentioned, there are a lot of different touch points where patients might have general questions about certain things about their medication list or about their diet, that we have information that's there. It's just hard to find. Like, you have to find the specific tip sheet. You have to go to your problem on the problem list and click the link, and then it opens that. And sometimes people have very pointed questions, and how can we give them pointed answers back to their pointed questions? And that's what a lot of this new evolution of the large language models provides, is very kind of bespoke, curated information that can answer the specific question you have. I think most folks are aware of some of the limitations of large language models, where depending on their training data, it may not give you a complete response, or it may give information that's related to the question you're asking, but not completely aligned with the answer that the provider would expect. So I think a lot of the work that's being done in our area, and Bill as well, is finding ways to curate and customize the experience the patient's going to have when interacting with these large language models, so that they can have this as an adjunct way to get more information, to fill their knowledge gap. I've had a patient tell me that, they want to send a message, but they didn't feel like bothering me. And I'm like, that's what I'm here for. But I think this gives them an outlet so they can feel like they can ask some of those, what they would consider silly questions. I say no question's a silly question, it's about your health, but they can ask some of those questions and just feel like they can get a better understanding of the scope of their care, so they can come to the table with even more advanced questions that we can go over in more detail.
Yeah, what you just said there about asking questions, because I can say from personal experience, with the health portal, I do find myself questions that I would never pick up the phone and call, or that will require a visit, to the doctor to ask. You just to be able to go into the portal, ask the question, and just be able to get that information is really invaluable and a time saver, and actually improves my experience in the care from the individual perspective. And so, Bill, as you work with key stakeholders within an organization, what are the challenges that are top of mind for them, especially related to privacy and regulations?
Yeah, so you hit that on the head. Privacy is the paramount concern that we see. Patient privacy, on the back end side, all of the data that's coming in, what's happening with that, and that privacy and security protection. But it boils down to, it's for now, without regulation by CMS and others that we're seeing coming, and we'll talk a little bit about that in some other areas that are interesting. But right now, that comes to your facility policy around how you're using all of this data. Make sure that everything that you use has got all the correct certifications. If it's FDA, software as a medical device, for example, with some of your assistive AI technologies, conversational AI and others. So make sure that's clear. If there's any UL, FCC is another big one for us. That is really big on outreaching to current clients and potential clients about additional services or things that you are providing to them or doing for them that were not in the original consent that they signed. So it is extremely important that in the consent that the patient signs, that it everything that your organization or partner organizations are providing to them are listed by name in that consent. So you have a one-to-one relationship with those on a FCC ruling that came out in December, or else you're a telemarketer, right? So you gotta stay away from that. That's just a foundational basic thing that we're saying. But as we're looking at conversational AI and it's reaching out to people, you got to make sure that you're covered there. So and the use cases for that. So make sure that the consent is complete. That's probably the most important thing right now that we're seeing on the privacy side of things. And remember that all of these, policy, reimbursement, use of large language models, ethical and legal, they've got to abide by your facility or organizational policies, and don't look at them as a barrier, but as a design consideration when you're designing these programs, or you're designing, if you're a developer, you're designing the AI tools, that you're keeping all of these things in mind. As Dr. Yaw mentioned, all of the large language models are different and take some particular customization for healthcare. Some organizations have already started to do that. Wolters Kluwer's, for example, we talk about that in the white paper, have been doing that. And then the other area in the consent is if you're going to use that patient's voice as a biometric or a biomarker, that needs to be identified in that consent form, so that then your conversational AI tools will be able to utilize that and provide additional guidance to the clinical team. One of the organizations that we talk about in the white paper could, using voice, identify if a patient had COVID-19, which Dr. Yao was talking about. 86% accurate on using voice to identify if that patient had COVID-19. So a great adjunct to clinical care, as, hey, this is a likely person, to have COVID, even if that's not been reported. They haven't reported the symptoms or anything like that. So we see a lot of great places where conversational AI can come into focus. Make sure your consent is good. I'm not an attorney, but anyway, that's good. That's good advice.
So let me see. I think you said consent is important, right? Okay, I think we can agree, and that's the biggest takeaway from what you're saying is, and I love what you said about being you're not making sure that you don't go into the crossing the line to being a telemarketer versus a telemedicine. So I love that. But one thing I want to follow up on something you said, Bill, regarding Medicare and the need for policy changes. Could you speak to that?
So, man, that is going to take.
Okay, wait.
Yeah, we could do a whole thing
a 30
on that.
second. Could you elaborate that?
Yeah, but in particular, there are time codes associated with remote physiologic monitoring, remote therapeutic monitoring, chronic care management, for example. They all have a time requirement, 20 minutes. That 20 minutes is when clinical staff, so humans, with that proper designation, clinical staff are reviewing that patient information, making changes to a care plan. There's, for the different codes, there's different requirements for what they've got to do in that 20 minutes. And for remote physiologic monitoring and interactive communication. So the interactive communication is real-time audio video. So at some point, CMS is going to have to look at this and say, okay, with all the things that conversational AI can do, where does it fit in? Is there going to be an additional code for conversational AI use in these parameters? So we'll see if that happens. The other thing is we keep seeing additions to codes and additions to things happening. Chronic care management came about in 2015, was augmented in 2017, remote physiologic monitoring in 2019, remote therapeutic monitoring 2022, chronic pain management 2023, home health having to report audio, video, or RPM technology use. They're not being paid for it, but started reporting that 2023, 2024, FQHCs, rural health centers and critical access hospitals have a G code, G0511 for remote patient monitoring. So the train is rolling, but the train is not looking at AI on that side of things right now. But one of the things Medicare is doing is on the payer side, and that's something we haven't talked about much today, but the Center for Medicare and Medicaid Services has issued strict new guidelines prohibiting Medicare Advantage insurers from using artificial intelligence and algorithms to unilaterally determine or deny patient care. So an insurer cannot deny coverage to a patient solely based on AI predictions. And what they've said is that those algorithms don't take into account the full picture of the patient's condition. But I think it's really interesting to see how Medicare is weighing in on this right now. And what we're seeing just in general is the current liability frameworks are inadequate right now to encourage both, safe clinical implementation and disruptive innovation of artificial intelligence. So, policy options that we've got, including maybe altering the standard of care. Maybe there's an AI standard of care, but being sure that AI, especially with some of the things that it can do with regarding hallucinations and inaccuracies, does not preclude someone from getting the care that they should get, so that insurance and indemnification and things need to be taken into account.
So point on that, and then we'll go to the questions. So Dr. Yao, could you speak to the point about standard of care as a clinician, your views on that? I would love to hear that.
Absolutely. And I want to echo some of the really poignant things that Bill raised around how privacy and the inferences you're able to make based on voice interactions is a very important thing we need to understand and define how we're going to use moving forward. As part of the Trustmark initiative, one of the things I've always loved about the work you're doing is making tools and certifications to help people understand whether voice workflows are trustworthy. And what does it mean to be trustworthy? Well, if something can detect whether you have COVID-19, some of these same workflows can detect your race and your gender. You can make inferences about someone's socioeconomic status based on the way they talk. And what are these going to be used for? In healthcare, we have the privilege of having this contract with a patient where we're solely invested in their well-being, and they divulge so much information, so much personal information, in hopes that we're able to arrive with them to a conclusion where they'll achieve a better state of health. If there's anything that gets between that partnership with the patient that violates trust in any way, the entire parameter falls apart. So we really need to ensure that the patients have a clear understanding of how their data is being used, managed, and that it really is solely for them as the stakeholder, the key stakeholder, going to be benefiting them. A little off topic, but there were recent reports about how people's cars were spying on them and sending insurance information to their insurance companies, and then their rates were going up. And people were like, well, I said they could, track my information so they could give me better statistics about how I was driving, but they had no idea this was happening, and this was affecting them in a negative way. So people are very mindful of ways that privacy can go wrong. And as we introduce these new care models that are highly contingent on having lots and lots and lots of data, we need to have a lot of transparency about how that data is being used. These data drive our models. They help make inferences, but as we know, data is as good as the data is, and garbage in, garbage out.
Garbage
So
in,
there could
garbage
be
out. Yes. Yeah.
biases in the data, just based on the way we're collecting it, not because of any malicious intent, but if you're training your data based on people that have been using remote care models, you have to wonder, well, who's not using remote care models and who's not represented in the data? And how can we generalize this data to a larger population if it's not based on the wider population? So looking at the evolving care models, trust is going to be a very important component of it. And then meeting the patients where they are, so that they can understand what they're getting out of this. Certainly, a benefit is that you don't have to drive all the way to Vanderbilt and maneuver our very complicated parking lot. That's a perk in and of itself. But in addition to that, by surrendering so much of yourself, and now in your home, now we have cameras in your home that can do the telemedicine for you. What is the trade-off with what you're surrendering, and what you hope to achieve with the better healthcare that you'll be getting out of the situation?
All right. Thank you, Bo, for that.
Hey, I just wanted to add something to that. So I talked about privacy as a principle, and then Dr. Yaw talked about transparency and accountability, trust as a principle. There are 6 principles that are talked about in the white paper. So that's the first 3, right? Privacy, transparency, accountability, and inclusivity, which really Dr. Yaw mentioned is that's the patient where they are, right? So we're including the patient where they are, whoever they are, right? And wherever they are in the US. The others are sustainability. That's a toughie. I mean, that gets to the basic economics of how things are used and additional cost per unit, those type of things, license agreements, all of those things. And then compliance. We've talked a little bit about that. We've see where CMS, Center for Medicare and Medicaid Services, starting to make some policies right now, kind of on the payer side, but that's going to continue to evolve and move over to the provider side and then covering patient care. So we'll see that. Other organizations like Open Voice Network may end up with some guidelines for ethics and utilization of AI in healthcare usage. So we'll see where that goes. Right now, it's an evolving landscape.
Yeah. Thank you both. And I appreciate the tie into the work and acknowledgement of the ethical principles, because that really is why we're here, and that is what we advocate for. So let's jump into the questions. We have a question from John Stein. We'd love to hear from Dr. Ya and Bill about the potential economics of conversational AI and the potential benefits to caregivers who more need, less people may be in danger of burnout. So could you both speak to that?
That is a wonderful question. With conversational AI, and again, the way it's evolved just in the past couple of years with the new transformer models that are coming out, and just the energy around this space. We've had all of these tools for many years. We've had AI for many years, but I think more recently, as the focus has been on having AI that is able to mimic human reasoning, human conversation, we're able to allow people to have more natural discourse with these tools. And there's a whole body of work looking at how some of these tools can be leveraged for counseling, for helping people talk through their problems, helping them deal with stress. And with caretakers, as we all acknowledge, that is a large task to take on, and often they forget to care for themselves. So thinking about tools and applications and things that people can create to help these folks not only help manage the care of their loved one, but also remind themselves to do breathing exercises, to do self-care tasks, and just even a place to speak and have a conversation. A lot of these tools now, you can just dialogue with it, and you can give it parameters about how to respond. So I think there should be a good amount of energy put into what kind of conversations are beneficial to these patients. How can we make sure that the information that's given back and shared through the conversational agent is going to uplift and direct them? And how can we help detect, with the patient's permission, with their compliance, with transparency, when there are signs of stress and depression and anxiety that need to be escalated. Because that's another one of the benefits of these tools is they're able to almost reasonably intuitively, as we would, pick up on some of these things in language and the way people are talking, the way people pause. And if someone allows it, is this a tool that we can have that they can take advantage of? Where if they're expressing dismay, we can have them guided to another professional, a human professional that can walk them through some of the challenges they're encountering.
Yeah, and I would say on the economics of things right now, organizations like us in the remote monitoring landscape or niche of healthcare are looking at AI tools. A lot of them are not developed in-house. We're looking at other experts in the field. So right now we're at kind of a higher cost if you're looking at from the organization implementing it like we would be, because we're layering in some of these technologies. We still have all the human backup. We still have all the human call center, all the human tech support, all the human clinical staff that we're using to help manage the patients. We still have all of that, but we're layering on some AI technologies. And in the next couple of years, it's not going to be tomorrow, but in the next couple of years, we're going to see where that real benefit is, where the AI can really reduce the cost of primarily what we think is going to be in the clinical staff area, the clinical staff that's managing these patients. Number one, that's going to help them be that clinical staff where we're seeing those numbers really drop. They'll be able to practice near the top of their license instead of doing a lot of this more mundane type work in these conversations and in this information gathering that we're doing. And we'll see them have a much higher level of satisfaction in their job. So that's the fourth part of the quintuple aim, right? When we're looking at that. So the whole quintuple aim is increased patient satisfaction and engagement, improved healthcare outcomes. The big place where remote monitoring comes into play is in improving those outcomes, reduced overall healthcare costs. Remote monitoring really helps with that. The fourth part, improved clinician and physician satisfaction. And the fifth part is improving health equity, the other goal of using conversational AI.
Very good. That kind of speaks to the next question, your last point, Bill, from Emily Troutner. Is telehealth addressing the need to interview patients in their native language, non-English speaking, also supporting follow-up plans to folks who cannot read? So what are possible use for interactive voice chat box support in for that?
Dr. Ya, I can see you ready to talk.
Yeah,
Oh,
she's
yeah, so
ready.
one of the
Yes.
most exciting evolutions with a lot of these conversational AI agents and the large language models is the ability to do some real-time translation and understanding of languages outside of the English language to facilitate communication in people that might not be native English speakers, to help with the kind of equity aims and goals that we have. So I think that, and also having a regular chat interface that can translate and bring people closer together. I think that's one of the real shining lights here that we need to do a lot more exploration of. I think there's still a cohort of underrepresented languages in the training data. Oita, you and I were not long ago at a conference where they were talking about how to ensure that these tools were going to be available to people
Right.
who didn't have languages that were as plentiful, because ironically, those are the same people that probably live in situations of very low socioeconomic status and may benefit the most from having availability of some of these tools. So I think just the work being done around that and some of the newer technologies that exist coming into play to help with the interpretation translation, not just via text, but also real time with voice, because as we all know, we're all voice enthusiasts here, but there's so much more in voice than in chat, where you can understand their tone and intent and things that they can convey. So I think that's one of the areas that's emerging that's I'm very optimistic about with regards to bringing people together and bringing more voices to the table.
Yes, the major AI vendors in the space right now, Alexa and others, already have usually about 20 languages that they can do instant interpretation in both directions. So we're seeing that expand. I believe I saw an announcement from Samsung a little while back, or maybe it was a TV commercial, that their latest Samsung smartphone has instant translation capabilities as an app on it. So already getting right into the consumer space.
Very good. Very good. All right. We have a few more questions, but we are approaching time. So I want to make sure, as I said at the top, we begin in on time. So can we this one I would, and we will make sure that we follow up on the other questions afterwards. So let's end with this one. Dr. Yao. Could you please share your story about using generative AI to decipher handwriting of physicians in Africa? We all know about physicians, so that would be a good story to end on, and then we will wrap up the webinar. So please.
Thank you so much for raising that. This was just such a fun and interesting interaction that I had with these large language models as they first evolved. So my grandmother, who is getting very old, she's in her 90s now. This summer in July, I'm actually going to Ghana to visit her. We were planning on traveling early on. My youngest son is 7. She's getting older. He's getting older. So I just wanted to make sure that they had an opportunity to meet each other. So we're going to be traveling in July. Many of my family overseas, whenever they have health questions, they call me for any sorts of health questions. I'm a pediatric endocrinologist. I take care of kids with diabetes and other hormone problems, but anything under the sun, they will ping me about. And I'm very grateful that they feel the ability to reach out to me. And I try my best to understand the questions to help point in the right direction, or at least do some background research to give them some understanding about what specialties they might need to reach out to, because that Ghana is one of the countries that doesn't have as fruitful resources as here in the States. So my grandmother was having some difficulty hearing, and over time her hearing was getting more and more diminished, and we weren't certain how serious the problem had become. So my aunt had taken her to an audiologist who performed some examinations to better understand what the situation was. And because of different access issues, they have a lot of handwritten notes overseas. So he had written up a handwritten assessment of her evaluation and passed that along to her. And my aunt, sent that along to me. It was a screenshot from her phone. She said, "What does this mean?" So I had this picture here of this note from this audiologist. And as a doctor myself, I can say that gentleman definitely had doctor's handwriting. So it was not too easy to scrut. So this was before GPT-4 had image reading in the OCR. So I actually found a handwriting application on one of the app stores, and I put this thing through the handwriting operation instrument to get back some information. And it did the best it could. It put some things in there, but even reading that high level, I'm like, I don't know how much sense this actually makes. And I took the text from that, and then fed that into GPT-4 and said, can you help me understand what this means? And I was delighted and surprised to find out that it was able to put together the information from that clinic note that the audiologist had written, and even some of the inferences it made. There were some things from the handwriting application that transcribed that just didn't make sense, like some characters where there was like a line or a dash, it just had that as a hyphen, but it actually extrapolated from that and reconfigured the words in a note that actually made sense, made clinical sense. And from that, I was able to read it high level, get a good understanding. Secondarily, I said to GPT-4, I'm like, can you help explain this to someone who doesn't know a lot about medicine? And it gave this really nice comprehensive description on the level that a layperson would understand. And I was able to pass that along to my aunts, who was able to pass it along to my grandmother. The best part was I was on the call with them explaining what the note meant. And I could hear my aunts yelling back, my grandmother, who again, this whole thing, because she's hard of hearing, translating back being, she said it means this. Yes. So the entire episode was it was so delightful. Bottom line, she needed hearing aids, which we've worked to get her fitted for, and she's in a better state of health. But this was really enabled and facilitated with these tools. Certainly, I think I probably could achieve the same thing by, phoning a friend or some other way. But just the ease to which some of these tools were available and you could patch them together and get that information. This is something I could teach my aunt to do on her own. So I think we're in a place where information and knowledge has been very scarce and still is. And as Bill has touched on, with the change in the economy, the landform, the regulations, people are going to have more access to these things, for better or for worse, because we know that they're not exactly foolproof all the time. And I think it's incumbent on us as people who are interested and understand this space to make sure that the tools that are available have this Trustmark seal of approval, have the care that's been put into them to ensure that the information going out makes sense, is transparent, and that people can rely on, and that knowing that they're humans in the background, ensuring that their well-being is top and foremost.
All right. Thank you, Bill, Dr. Ya. Thank you both for taking the time today to share your insights, and thank you also to you who contributed to the white paper and the other contributors to the paper. Nathan, the final slide, just as we wrap things up, I'd like to thank all of you who joined the webinar today. We appreciate you spending this time with us, and your call to action: download the white paper. Please use this QR code, and it will allow you to ask any additional questions you have, or information that you may need, and ways for you to get involved. So contact me, and if you have any additional questions or comments. But there were a couple of questions that we didn't get to, but I'll make sure that we follow up offline and provide answers to that. So again, grateful for you, and grateful for you sharing your expertise and your time, and for really living up to our charge, our mission of worthy of trust. And we find you and appreciate you being trusted advisors on our journey. So with that, we will see you next time.